Up with chapter 1. I apologize for my absence. I know we were doing Kahoot the other day and we went through a discussion, I believe, of causation. We're into the historical, we've made it all the way through this whole discussion about the supernatural tradition and the history of explaining mental illness or abnormal behavior. I know I asked a question about Galen and Hippocrates on Kahoot. And so what essentially is important here is that Hippocrates kind of is one of those Greek philosophers that is acting upon intuition, and he is philosophizing that abnormality is actually a physical disease. And so he really emphasizes the idea of hysteria, but more specifically, he is putting forth this idea of the imbalance of humors, which later on humors then works into being like the trait theory there, to where we have an imbalance or a certain combination of traits that then represents a personality and or normal versus abnormal behavior. You guys are familiar with that: choleric, sanguine, melancholic, etc. All right, so what they said, essentially, the Galen Hippocratic tradition was to bleed individuals to control their black bile, their yellow bile, their blood, their phlegm there, and by reestablishing balance in that, then we could eliminate something like depression, and so they would this became part of medicine. This became really the foundation for a biological perspective in a disease model, and then filtrated through medicine, filtrated into psychology, etc. So they were very much into bloodletting. They were very much into the use of leeches, all types of medications that they would insert in all different parts of your body to encourage you to sweat, encourage you to vomit, encourage you to lose blood, in hopes of rebalancing your behavior, essentially. And what would happen typically is that you'd wind up dying because they would weaken the system so much through all those processes. Then in about the 19th century, we saw this onset of syphilis there. Now, syphilis has been around for more than the 19th century, but it began to be equated with mental illness and linked to madness. And that's because syphilis can actually produce, not just physical problems, but it can produce mental illness such as psychosis there. So Pasteur comes along and discovers that this is a bacterial microorganism. Later, they discovered penicillin, which is a successful treatment for syphilis. But it bolsters the biological perspective, that mental illness is actually due to a physical illness. But other reformers come along, and they also believed that mental illness had physical roots. And so they kind of pushed for that kind of original Hippocratic Galen kind of perspective about the biological influence, to move from a European kind of position to becoming something that we begin to accept in the U.S. So what they then believed that one, we should biologically treat mental illness, but the environment in which that treatment should occur should be much more humane in our psychiatric facilities. And if you watch all these scary shows about, haunted psychiatric facilities, and they relive some of the early biological treatments, such as electroshock, lobotomy, etc., then truly, that it was a horrific time in terms of biological traditions and treatment of mental illness. Where did the idea of insane asylums come from? It originated in Europe. Actual clinical treatment, clinical hospitals where you received humane moral treatment, really originated in the Middle East. Clinical psych is really seen as originating in the Middle East. Moral treatment of patients and trying to help them do talk therapy, kind of seen as originating in the Middle East, yet you don't really see that in our textbooks. So we need to expand how we study multicultural psychology. So in Europe, you have these massive institutions, such as St. Elizabeth or Bedlam, where the mentally ill are treated. And they're very elaborate and very pretty. They've got very, very nice gardens on the outside. People walk by them and go, wow, isn't the governor so nice to our poor indigent people? However, inside those treatment programs, they weren't really treatment programs. They were simply warehouses where people were chained to the walls. They were, genders were mixed together. They were massive type of, almost dormitories, but not really dormitories, more like stalls. People were chained together, chained to the wall, made to sleep on the floor, made to sleep on hay like horses, nude, fed poorly. Not everybody in there was actually mentally ill. They had children, they had women, they had people that were retarded, they had people that were simply poor and indigent. How did they get there? Certainly not by a psychiatric referral. They could be, a woman could be referred by her husband who was fed up with her, tired of her behavior. A child could be referred there for simply abandoned there. Spend their entire life there, actually. Usually it was a local county clerk almost that rendered the decision that that person was mentally ill and needed to go into that program. But what we saw in that program was that the governor was all concerned about making it look like he was very much concerned about indigence in his city, but obviously not. And then the administrators of these hospitals, what would happen is that they would get into the hands of a family, and you would have multiple generations of people running these hospitals and just coining as much of money as possible, putting it in their pocket and treating the patients horribly. So not so much moral treatment going on. A couple of years back, I had the good fortune of going to London, and that was one of the very first places I wanted to go, was to go see St. Elizabeth or Bedlam, and was able to retrieve a book from there. It's now a military museum, but I was able to kind of get an idea after all the years of teaching about St. Elizabeth. And St. Elizabeth still exists, but it's out in the country now, away from London, and much more improved conditions. But I didn't get to go out there and see any of the original, I guess, instruments of punishment that we could say. But as this idea drifts to the United States, we do develop these massive campuses across the United States that are institutions, and they are housing thousands upon thousands of people in these insane asylums. And they're still indigents, and it's horrible psychiatric care, because really at that time there are no psychoactive medications. There are no what we call psychotropic meds. There's no antipsychotics, no antidepressants, no nothing until the 1950s, whenever we begin to produce a thing called lithium and thorazine. And thorazine is one of the old antipsychotics, has horrible side effects, and lithium is the tried and true salt, essentially natural salt that we converted to medication for bipolar disorder to this day. So psychiatrists were helpless, really and truly, and that's one of the things we need to kind of understand, is that you had good people working in just really overcrowded, horrible conditions, nurses working in horrible conditions, trying to provide basic care for individuals that truly some were very, very chronically schizophrenic and severe problems there, and abandoned by families. Now, if you had a mental illness and you were wealthy, you didn't go into an insane asylum, an institution. You went to a sanitarium, and you were treated like it was like a spa, a stay away from home spa-like treatment. You didn't necessarily get any better, so the two treatment programs, really in comparison, the only reason there was any difference in treatment was that one person got treated better than the next person in terms of just day-to-day care. But in the insane asylums where the indigent folks were, like I said, there were thousands of people in these. And there's an insane asylum right at the edge of the University of Alabama in Tuscaloosa that's called Bryce Hospital. And one of the very first places I went to visit when I moved to Alabama was to Bryce Hospital. And you drove onto the campus, drove right into the doors or the gates of Bryce Hospital there at the edge of campus, and you could look up in the window and you could see hundreds of people just kind of standing in the windows. They were barred windows, and they were in their hospital gowns, and these were the chronic patients that had been there forever. Now, mental health reform has changed in the state of Alabama, and that those institutions people have been deinstitutionalized, and so you typically might see them in group homes, on the streets, etc. So some of the early forms of treatment in those early biological treatments in those type of institutions were things like electroshock, lobotomy, insulin injections, major tranquilizers later in the mid-century, 20th century, and then minor tranquilizers, which are some of the things that are still prescribed today, but heavy on some really strange treatments like electric shock. Now, electric shock, folks, is still used today. It's used for those major depression cases and some schizophrenia cases where there is no change after just a ton of medications. In other words, medications 32, 25, sets of different medications have had no effect. And this person really is at death's door because they maybe are so highly suicidal that they demand just somebody right by them around the clock, or they're so responsive to their hallucinations and delusions that they've just become so incredibly dangerous to themselves or others. So electroshock has to be ordered by a psychiatrist and has to be justified medically there and done in a hospital. And it's not as crude as it used to be. It used to be they would be shocking. They'd be running this electrical impulse through your brain, both sides or one side. That would cause muscle contractions, cause people to break their teeth, break their bones, etc. Now they give you muscle relaxants, like I said, doctors ordered, in kind of the end of the treatment kind of response. Crude surgery, lobotomy. I have put on my tap the movie The Lobotomist. And if you've never seen that, I think it's very important for you to watch the little, some of the clips of that. And it explains the role that lobotomy started to play in the United States. And boy, they caught on like a trend, like a diagnostic trend almost. It was a technique that it was a see one, do one, teach one kind of approach. And so I really encourage you to look at that and see what the principles and the ideas were behind lobotomy. Lobotomy had some great initial success. However, it had some horrible, horrible side effects for those people that experienced lobotomies. And there's some books out by people that had lobotomies, and I don't have that name in front of me, but you can certainly make that a whole research topic in itself. And then there was the insulin injections. And what by accident they found out was that insulin actually calmed psychotic patients, calmed them down from responding to their hallucinations and delusions, etc. So they kind of would start getting carried away with insulin. Well, what happens when you produce too much insulin in the body? The pancreas begins to overreact and go, wait a minute. And so there's lots of negative side effects for the insulin injections as well. And then major tranquilizers are discovered, minor tranquilizers are discovered, antipsychotics are discovered, all about 1950s, like I said, and treatment begins to change dramatically. We begin to see the elimination of so many cases of lobotomy, so many cases of electroshock, much more humane treatment. Certainly, fewer people are institutionalized for their entire life. But then we roll into some other periods of federal government and decisions made by politicians to where, we get deinstitutionalization. And in fact, some individuals, need around-the-clock care. So there's lots of discussions about that there. But that's the 1960s, 1970s, during the Kennedy era that we can talk about. That's called the child guidance movement, but we'll come back to that. So obviously the consequence of biological tradition is that mental illness gets equated just like with physical illness. And therefore, we believe that treatment can be, like a disease model. Emil Kraepelin, I mentioned him before, talks about the classification of disorders. And so in a classification system, what we're trying to do is we're trying to all get on the same sheet of music, say these particular list of symptoms and fit this particular diagnosis. We begin to have an agreement about the causality, and that we talk about them having very specific, unique characteristics to them, symptoms, behaviors, emotions, and age of onset, as well as causality. So Kraepelin adds to our ability to classify disorders, which is significant. That's very significant there, that we all get on the same sheet of music and know what we're treating. So, as I mentioned, moral therapy. Moral therapy came about in response to Dorothea Dix, I can't remember, it's Dorothea Dix and someone else, that are responding to the horrible conditions that they see in these institutions. And so this becomes popular in the first of the 19th century, moral referring to psychological emotional factors. The main idea was that patients needed to be treated as normal as possible in a normal environment. So it led to much more humane treatment in institutions, and it really encouraged the patients to be unlocked from the wall dressed, listening to music, being fed appropriate food, having social interaction, practicing, communication skills, etc. So who are those people? Dorothea Dix, as I mentioned, for the mental health hygiene movement. Benjamin Rush, who was leading that reform in the U.S., and Pinnell and Poussin, who are the ones that said, don't restrain these patients anymore, stop tying them to the wall. There, but Dorothea Dix comes in, and you can read some of her letters in the National Archives, and she is just screaming when she gets in front of congressmen, and she was saying, "How dare you treat people this way?" And she goes on this litany and this tirade time and time again until she finally beats congressmen down and politicians down into submission. And this moral therapy really kind of takes on. So she is a champion of reform during that time. So now, what happened to this? What does asylum reform then lead to? Moral therapy begins to decline because it's harder to deal with the sizes of the population in these institutions. So they maybe have been pushing for more humane treatment, but when you have thousands upon thousands upon thousands with individuals that are maybe non-responsive to treatment, but they're certainly showing some significant symptomology, it just is hard to treat large numbers of individuals with inadequate staffing and inadequate treatment interventions, etc. So what happened to moral therapy is that other psychological therapies came along. Okay, and that's pretty common, is that we get other psychological models. So who pops up on the radar? Freud. So Freud is a very big proponent of, he's not against moral therapy, but he's saying that you need to go a little bit further. Moral therapy, really is focusing on very conscious, voluntary kind of behavior. Whereas Freud comes along and he says, I think that abnormality and mental illness probably exist at that unconscious level, and it's driven by a biological set of instincts for life and death. And he's significantly influenced, not so much by one particular psychological perspective, but he's really kind of influenced by that biological tradition. He's influenced by Darwin, evolutionary theory there. And so he wants to offer an explanation for not just abnormal behavior, but personality development, etc. So he comes up with this idea that we are driven by this life-death instincts that is biological in nature, that essentially is evolutionary in nature, really certainly points at that idea of adaptation, where the species is surviving as a product of procreating their own seed, and then aggressing and competing and causing competition to die off there. He says that instinct is both life and death, and it is represented by the id and the id. The id being life and death instincts, being the aggression and the sex. But he says then there's also this ego that's involved, which is awareness of the reality. It's rational. It mediates between that ego, between that id and this part called the superego, which represents our morality. So within our levels of consciousness, we have this interpsychic conflict going on. So the superego wants to supersede and take over the id, and the id wants to rise to the top out of this reservoir of sex and aggression and take over. So it's like definitely the devil and the angel on each shoulder. And I think there's a YouTube video that really kind of represents the id and the superego pretty well if you want to look that up. So the superego, like I said, is at the pre-conscious, unconscious level, and it is your conscience, and it's driven by your moral principles. Your ego is that mediator between the two, the id and superego, and it's very logical and rational. It's very much based in the reality principle. It's like, hey, there are rules out here, and we need to chill out a little bit there. So it's based in reality, but it's aware of what's going on with the superego and the id. So it kind of can float between the conscious, the preconscious, and unconscious into seeing all this dynamic here. Seeing is kind of loosely used there. And then there's this id that's very illogical, it's emotional, it's irrational, it's based upon pleasure principle, which is all about avoiding pain, seeking pleasure. Now, what is that poor ego going to do since it's in this struggle between the id and the superego? It's going to have to constantly deal with three types of anxiety: real anxiety, neurotic anxiety, and moral anxiety. Moral anxiety is that superego going, okay, guilt, and then neurotic anxiety is coming on by that because that sex and aggression tendency is trying to break through. And then real anxiety is, hey, there's something really there that's going to cause us problems there. So the ego is constantly in this fight to survive and to keep this balance between the id and superego. So what does it do? It has to compensate. It has to do compensatory behavior. It has to compensate. It's just trying to reach an equilibrium. And it's not really growth oriented. I just want to chill. I want to be equal between these two instincts and impulses that are going on here. So what does it do? It manages that anxiety by using, and the conflict that's coming there, through using defense mechanisms. And so, here's a series of about Let's see, 5, 7 of them. Displacement, denial, rationalization, reaction, formation, projection, repression, and sublimation. You guys can look those up because those have become so commonplace in our language today. But know that they are compensatory. Know that they are the effort by the ego to maintain itself because of the struggle between the id and the superego. Now, Freud does actually have a discontinuous theory. And what do I mean by that? That means that there are stages to his theory and there are ages attached to those stages. So there are stages of psychosexual development. And why is it called psychosexual? Because at each one of those stages, there are erogenous zones that are identified. And that's where that energy from that it is welling up. And it's also where that conscience for that superego is going to well up at certain identified stages. So think of the stages as being much like the house of your personality, the house that represents your behavior. So we have all these stages that are oral, anal, phallic, latency, and genital. And there are, again, erogenous zones in each. And how those stages are essentially addressed by the significant people in our lives, i.e. mother, child, father, child, is going to determine, do we have any of that leftover libido or sexual aggression energy, or that leftover conscience, superego, super puritanical, in terms of how we resolve that catharsis, that experience of that energy there. So if I am at the oral stage and I'm an infant, I'm into, sucking my fingers, my toes, breastfeeding, and or the pacifier, my interaction primarily is with mother-child. And so if mom gets all out of shape about, I need to, she can't breastfeed, and the baby has to bottle feed too soon, or she's not going to let the baby stay on the pacifier too long, or slaps the baby's hands away whenever they try to suck their hands or their feet, or doesn't let them suck whenever they're trying to suck her fingers. The baby just incorporates that libido energy and it stays right there. So what do they do with it? Later on, they either become either very rigid or they become very explosive, rigid and orally explosive. So you might get a person that is really into being sarcastic, and just running their mouth 24/7. You might get a person that is like constantly chewing gum, constantly maybe restricting their own eating. They're, putting stuff into their mouth, etc. So you get all kinds of abnormalities. That's a product of simply that what happens with those instinctual energies there. And then later on, as we get into the latency stage, we chill out for a while. And we wait for that genital stage to arrive. And that genital stage really is a reflection of how our dad began to play a role in our lives to kind of equal out that sexual desire for mother, give us a sense of morality, get us balanced into an appropriate relationship with him, and seeing our mother in an appropriate context as well as our father in an appropriate context. And hopefully then by the genital stage, you've moved into normal adult relationships as a product of your Oedipus complex as a guy or your electric complex as a girl. Now, later developments in psychoanalytic thought. Now remember, we're talking about psychological perspectives. We left biological. Now we're into the second perspective. There's about 7 psychological perspectives overall. So we've been biological, and now we're talking about psychological. The first theory under psychological perspective is the psychoanalytic theory. Now, an expansion of the psychoanalytic theory occurred with Anna Freud. And Anna Freud really wanted to grow beyond her father, and she worked extensively with children. She did maintain a lot of the principles of his theory, but she wanted to concentrate on the ego a lot more than concentration on the id. And she wanted to concentrate a little bit beyond just the mother-child relationship. And so what you're going to see is that Anna plays a very significant role in clinical child psych and a very significant role in developing the idea of play therapy. So now she was doing psychoanalysis with children, but she was really kind of using play therapy as a means for getting at their ideas, their memories, etc. Other people that followed along behind her in that modernized psychoanalytic theory into psychodynamic theory were Melanie Klein, Otto Kernberg, and they concentrate on this idea of object relations theory. So now that's really important, object relations theory. And what they emphasize is how do children essentially incorporate objects into their life? How do they incorporate their mother into their lives? How do they incorporate their father? So those objects are significant others, their images, their memories, their values. And so, sitting down to do psychodynamic theory at this stage is much more about, well, how do you see your mother? What role does your mother play in your life? How do you think she got to that role in your life? And what impact do you think that has now in your life? Not so much in the, oh my gosh, how did she damage you? What happened to your id? What was going on during toilet training or the anal stage of psychosexual stages, etc. Now, if that information comes up, okay, that's part of your incorporation, but it's not your end-all be-all in terms of outcome for your life, okay? So much more current psychodynamic object relations theory. Now, Neo-Freudians started with Anna Freud, extended through Jung, Adler, Erickson, Horney. Those are all guys that are Neo-Freudians and way beyond that. Now, they departed from Freudian thought and because they decided they want to de-emphasize the whole role of sex. And so what happened is that these individuals began to, and I forgot Adler too, in that group. So what they began to do is they began to concentrate on ego. They began to concentrate on the individual, concentrate less on the id, concentrate less on the mother-child relationship, concentrate less on the past, much more on the social environment. And so each one of them kind of picked and chose the principles of the Freudian theory that they hung on to. Some were more traditional than others. And then others got way, way far away from Freudian theory as it grew, okay? So Jung is one of those individuals that was identified along with Anna Freud to be a protege of Freud's. And you can read the arguments and the fallout that occurred between Jung and Freud and their letters to one another. And Freud was basically, in many ways, a narcissistic megalomaniac who wanted everybody to stay pure and loyal to his theory. And then anytime everybody started kind of, pitching a little bit of an idea, maybe a reconceptualization, emphasizing a different part, Freud would absolutely have just a fit there because of he saw that as being disloyal to him, messing up his theory, messing up his status, messing up his legacy, etc. So Jung was the first one to really set him off. But in truth, he had arguments with Adler, Horney, Fromm, Erickson. He just had arguments with everybody that wanted to differ from his theory. So psychoanalytic theory is considered the talking cure, okay? And why is it considered a talking cure? Again, under psychological perspective, specifically talking about one theory, psychoanalytic theory. He says because we can, through talk therapy, uncover the real problem. Problem with doing psychoanalysis is that it's an incredibly long therapy time period. It takes years and it costs a lot of money. It involves techniques such as free association and dream analysis. Free association being, what's the very first word that you come to? If I give you a stimulus word, it comes to your mind. Dream analysis is tell me your dreams and let's interpret them, both their manifest and latent content. Manifest content is, what are you telling me? Latent content is the symbology there. It examines transference, countertransference, and this is still important. This is a very important lesson that we do take away from Freud's theory. Transference would be essentially projecting. I'm transferring my experiences, my thoughts, my emotions, et cetera, onto you as the therapist. And countertransference is just exactly that. I'm responding as your therapist with my stuff in return. Not necessarily always a healthy thing there. So what do we think about Freud's theory? No validity, no reliability, only used case studies. You hear that word, you should automatically think, okay, here's a problem. There's no replication. It's difficult to prove because there is just no really objective method of measurement and research there with it. So now we're going to shift over to another theoretical approach. Let's kind of talk about it that way. We're talking about 7 psychological perspectives, and under the psychological perspectives, we're going to outline a psychoanalytic theory, and now we're going to talk about humanistic theory. So to differentiate there for you. So who are the people that are affiliated with humanistic theory? That's primarily Maslow and Rogers. You guys have probably heard about this too. But what are the major ideas here? People are basically good, and people are striving for self-actualization, being all that they can be. Humanistic theory, as it pertains to person-centered therapy. Now, this is Carl Rogers, who comes up with person-centered theory and/or person-centered therapy or client-centered therapy. For many of you that are taking counseling skills, you've heard of him. So, very interesting thing about Carl Rogers is that he started out in the seminary, and as he got more into analyzing himself and why he was in seminary, he decided to essentially reject the seminary, reject theology, and on some levels really begin to reject God. So, a little bit about him there. In person-centered therapy, essentially what is happening is that you have an individual that has all this potential to be their real self. However, in their relationships with other people begin to lay conditions on us. I'll love you if, okay, you made all B's except, you got this C here. They put conditions on us. They look at us, funny. Like, what are you wearing? That's unacceptable. It's a condition. And we get conditions placed on us every single day by the people around us. So that creates a burden in us that we begin to vacillate between who we really are and who we think people want us to be. And so we begin to perform like we think that ideal self should be. And so we really create misery within ourselves, and we really begin to lose our real self. And so what he says is that the way to help a person move beyond that vacillation that's going on between the real and ideal self is to set up a unconditional positive regard scenario there, to where the therapist can convey that empathy as unconditional positive regard, doesn't lay any conditions on the other individual, doesn't add their control into it. They don't sit there and add their interpretation. They simply are doing some active listening. They're doing reflective listening, making sure that they're hearing exactly what's being said. They're not doing interpretation. They're not giving advice. It is just very much hands-off. Let's let the person move through that vacillation and discover who they really are and make the decision about whether or not they're going to respond to other individuals' conditions. So now, there's really no strong evidence research-wise to show that these types of therapies work in treating mental illness. It is typically a therapy that works incredibly well with people that are just having normal life stress, not really suffering from really severe psychopathology. So now, the third theoretical point of view, we've done psychoanalytic, we've done humanistic, and now we're going to talk about behavioral, is derived from a very scientific method and scientific approach to psychopathology. And you guys recognize these names: Pavlov, Watson, Thorndike, and Skinner, right? So starting with Pavlov, now, why do we talk about Pavlov and Watson together? Because Watson was the first person that took Pavlov's idea and said, you know what, this can apply to humans, whereas Pavlov was just working with dogs, right? Remember that? So it is a ubiquitous form of learning. Now, what do we mean by the word ubiquitous? It's just kind of discovery, surprise. Pavlov, by accident, discovered unconditional stimulus causing unconditional responses and conditioned stimulus causing conditioned responses. And essentially what Pavlov said, and Watson later confirmed, was that people learn associations between neutral stimulus and stimulus that already have meaning. So a neutral stimulus for Pavlov would be the bell. And a unconditioned stimulus, or a stimulus that has meaning, but really you've not learned to associate the two, excuse me, would be like the bell being paired with the food. Now, he uses this word conditioning. Conditioning means learning. Burn that in your brain. Conditioning means learning. So I'm learning that this stimulus that I thought was just, okay, there's an object, really has meaning. And I learned to equate that stimulus there with being fed and feeling good or feeling happy, etc. I learned through a pairing, and that's a very important word, pairing. Putting two things together, I learn. If I have these new tennis shoes, hey, everybody smiles at me. If I have this new outfit, hey, I get a date. There's a pairing between the two stimulus and response. I have therefore learned: buy the tennis shoes, get a smile; buy the dress, get a date. Buy the M&M, eat an M&M, feel pretty good. So we learn very, very quickly through these pairings. And so we began to acquire behaviors, and just as we can acquire normal behavior, we can also acquire abnormal behavior just through a pairing of unconditioned stimulus, unconditioned response with neutral stimuluses that eventually lead to a conditioned stimulus, conditioned response. So that conditioned response answer that we saw in Kahoot, why was it a better answer? Yeah, it's a learned response. But when we say conditioned stimulus and a conditioned response were paired, then a conditioned response occurs as a product of a conditioned stimulus. That answers as to the why, and the why being, yeah, you learned it, but there was a stimulus and a response affiliated with it as well. So behaviorism really rises up in response to psychoanalysis. The individuals of the behavioral movement, and this is kind of, we call these schools of thought, because in each school of thought, there's a founding father of that school of thought, and then there are all their students, and then all their students, and all their students. So it becomes a school, and it becomes a legion, essentially, of people that are going, this is the way that is the best way. This is what psychology should study. Here are the techniques. Here's how we should assess. Here's how we should diagnose. Here's how we should treat. So you have journal upon journal upon journal of articles where people are saying, this is the way to go, and people going, no, it's not. And then people are developing, new schools of thought. And that's really what leads to this whole fragmentation of psychology that people can't stand. It's what the natural sciences look at us and go, you're not a science because you don't have any standard rules and laws. Now we have individualization, is what I'm saying, which is what medicine is now just learning about, individualized medicine for patients. But that's another day, another argument. So behaviorism really challenged psychoanalysis. It challenged other non-scientific approaches, such as humanistic psychology. So the very earliest pioneer was Joseph Wolff, and he talked about systematic desensitization. So systematic desensitization. If I keep pairing, again, that word, a good feeling with a negative feeling, then I systematically can desensitize you to something that maybe is a fear response. So let's say that you're afraid of spiders. And let's say that I have a spider in one hand and a Twinkie in my other hand. And I begin to show you the Twinkie and the spider. Well, you love Twinkies, but you're really fearful of spiders. But you love Twinkies. So that pairing the two together, you can't have two opposing feelings there. And so systematically, I can desensitize you to that fear object by pairing it with the object that you love that gives you good feelings and that are tasty. So, all right. So the other type of conditioning is this idea of, and back to Watson. Why is Watson classical conditioning? Again, he applied the ideas to humans. And you remember John Watson had this long experience of experimenting with baby Albert and a couple of other children where he paired loud noises with animals that the babies were not aware of, didn't know anything about, had no fear response to. But eventually, after pairing it with a loud noise, furry things became objects of fear. So that's that baby Albert story in kind of in a nutshell. But this operant conditioning idea is started by a guy by the name of Thorndike. And Thorndike experimented with cats. And so what he did with cats is he created a puzzle box. And in that puzzle box, there were a series of steps that the cat had to go through to get out of the door to get to a bowl of cream or a bowl of milk. And so amazingly so, this animal, after accidentally discovering, here's flip this switch, pull this rope, etc., releases this door and gets this reward. So the question is, will that cat remember all the steps to get out of that puzzle box and to get to the reinforcer? And the truth of the matter is that yes, it did. And so he calls this law of effect. And the law of effect essentially is this, is that, every time I do a behavior that leads to a reward, I'm more likely to repeat that behavior. There you go. Why do we have 500 pairs of tennis shoes, Converse tennis shoes? Nike tennis shoes, guess what? They've been paired. They've led to a good outcome. People smiling at me. I'm looking fresh. I'm stepping pretty lively. I'm going to go get another pair because I like that feeling so much. So Nike wants to thank you for that. All right. So the idea of law of effect is really talking about reinforcement. Well, B.F. Skinner comes along and he's discovering Thorndike's idea, and he's doing these experiments and ideas in graduate school, and he's saying, you know what, these ideas can apply to people, not just cats. So you can see comparative psychology alive and well through classical conditioning and operant conditioning. So we've taken animal experimentation and we've said, well, If animals will do this, well, people do it too. And lo and behold, yep, people can be conditioned just as easily and sometimes easier than animals can. So Skinner discovered that, yep, if I give a positive reinforcement, I'm much more likely to get that behavior to occur again, thereby validating Thorndike's law of effect. He also discovered that, yep, there's different types of punishment, that if I introduce a punishment, I'm more likely to stop a behavior, not necessarily change a behavior, but stop a behavior. And so he comes up with the ideas of positive and negative reinforcements and positive and negative punishments there. And so it's, again, ubiquitous. It's like, how does this occur? It occurs through pairing. And so he says all of our voluntary behavior can be controlled by the consequences, and consequences are not negative here. Remember, consequences are both positive, negative reinforcement, positive, negative punishment. So learning, that's really what we're talking about. Learning and conditioning, theories of learning and conditioning, then eventually lead to behavior therapy. And behavior therapy is very time limited, very direct, and there's lots of evidence to show that it's effective. Definitely an efficacious kind of treatment. What are we setting out to do in behavior therapy? We're trying to create new associations by practicing new behavioral habits. And habits are simply continuously reinforced behaviors that we're going to repeat there, and or reinforcing useful behaviors with positive consequences. So what's an example of a behavior therapy? Your teachers do it to you all the time. Whenever you're a little kid, you have behavior mod programs. You have token economies that if you sit in your chair 3 days this week, you'll get a green light. If you sit in your chair only 2 days this week, you get a yellow light. If you sit in your chair no days this week, you get a red light on the stop sign. Okay, so how many days you have to have of green light? 3 days. Well, at the end of 3 days, you've done the behavior I wanted. I've reinforced you. I've given you your green light. You get to go trade that in for a bag of candy, right? That is a behavior modification. Here's the behavior I want. Here are the positive consequences. You get a green light. And here's the positive reinforcement, the candy. Here's the behavior I want. Here's the punishment that you'll get. You get a red light, and you get no candy. So behavior mod is used all the time in psychiatric hospitals, with little kids, in preschool, you name it. And the interesting thing about it is that how we analyze what reinforcement and consequences are. Now, I gave the tennis shoe example a while ago where somebody smiles at me. Is it really that simple? Pairings between putting on a brand new pair of tennis shoes and somebody going, hey, and smiling at me, that's conditioning? That happens that easily? Yes, it does. Yes, it does. So how do you know if you're being conditioned? Well, first and foremost, what's the behavior that's being identified that someone wants? Secondarily, know yourself. What are your primary reinforcers and what are your secondary reinforcers? A primary reinforcer is going to be the feel good, being nurtured, being smiled at. Secondary reinforcer is going to be something like money. Primary reinforcers don't lose their value as easily as secondary reinforcers do. That's proven at the grocery store every single time. Whenever the kid has the fit at the checkout counter because they want candy and their parent goes, fine. They give in, they pair the candy with the tantrum, and so the baby goes, okay, hey, this worked the first time. We try it again. But eventually that wears off, and they want 2 candy bars versus 1 candy bar. Then there's this idea that we've arrived at today in psychology, and it's really kind of an integrative approach, or what we like to call a biopsychosocial, another word for it, biopsychosocial. And it essentially says that, we really develop psychopathology by multiple factors. We might have it, come from our mother-child relationship. We may have it come from the fact that our ideal self has been denied. We may have it as a product of the behavior modification, reinforcers, punishers I've been exposed to. We may have it as a product of sociocultural factors, my environment. We may have it as a product of genetics that I've inherited there. But it's very unidimensional it's very multidimensional and rejects the idea of one reason being the cause of abnormality. So we always have to look at the reciprocal relationships between psychological, social, and experiential factors. We have to remember that abnormality is very quite complex, multifaceted, and evolves. And even the science of understanding psychopathology, clinical psych, has really changed across time. We've gone from seeing things as supernatural to really looking at, neuroscience now and seeing how are the brains of people that have psychopathology different from those that don't there, so that we can account for biological influence. We look at social influence. We can say, well, in our society today with racism, that's a social factor that actually inhibits, good, healthy growth in individuals that have to experience it or that do experience it. We can look at the psychological thing in terms of what's the impact of fathers not being in the homes there. So we can just go on and on and on and on. And that's why it really leads to the necessity of research to say, well, which one of these factors is really contributing the most to this particular form of psychopathology, its cause. Maybe because it's going to give us some information on how to assess it. Maybe it's going to give us a better piece of information on intervening and such. So any one of those areas that we've mentioned in this integrative approach is a rich platform for research in terms of trying to discover, what are these things that are contributing to psychopathology and how do we help people.